Hey guys, my name is Laura Koch and I am doing Guinea worm disease. Guinea worm disease, also known as dracunculitis, is an infection caused by the nematode roundworm Dracunculus medinensis. The main things that are important is the genus is Dracunculus and the species is D. medinensis. Its family is also Dracunculidae, and some of the subspecies, as you can see, are Dracunculus insignis, Dracunculus lutrae, Dracunculus medinensis, Dracunculus esophageus, and some others. Prevalence: the Guinea worm disease is endemic in 12 to 13 countries, and all of them are located in sub-Saharan Africa. Most cases are localized to Sudan. This is due to the civil war going on in that area. From 1986 to 2003, the number of cases has dropped from 3.5 million to 33,000. And in 2017, there were only recorded 23 to 26 total human cases. There are no current cases in the United States, so the concern for it is minimal. Other than the 26 cases this year, there have been no other current outbreaks. Guinea worm disease was earliest recorded in around the 15th century BC in Egypt. It was also kind of found in tombs with mummies and sometimes in sarcophaguses. Similar cases occurred in Persia and Israel around the 11th century AD. In the 18th century, Carolus Linnaeus finally identified the organism as a parasitic worm, and in the early 1920s, the eradication program was implemented focusing on water sanitation. These have continued into the 21st century. In 1980, the WHO collaborated with the UN to eradicate dracunculitis. Countries with Guinea worm disease that have been eradicated are Pakistan, Iran, and India. And a quote on the CDC website says, in May 1991, the 44 World Health Assembly endorsed the goal of eradicating dracunculitis by the end of 1995. As we can see, with the 26 cases in 2017, this is not the case. Outbreaks and endemics. In the mid-1980s, there was an estimated outbreak of 3.5 million cases of Guinea worm disease that took place in 20 different countries, 17 of which were in Africa. In 2007, the numbers dropped to around 10,000 cases. Numbers have statistically decreased to around 25 cases. So as we can see, in probably the next 5 to 10 years, we will probably see almost 0 cases. D. medinensis is transmitted through a cyclic process. Humans drink water, which is contaminated with water fleas, who have digested Guinea worm larvae. The copepods die and release the larvae, which penetrate the host's stomach and intestinal wall and enter the abdominal cavity. Once the larvae reach the abdominal cavity, they mature and mate, usually over a period of 10 to 4 months. After this, the males die and the females travel upward towards the surface of the epidermis, forming the blister, which is the trademark of this disease. Often, these adult worms become 60 to 100 centimeters long. This is about 2 to 3 feet, and it's as wide as a cooked spaghetti noodle. When the host uses the water to relieve the discomfort and pain, the female, somehow sensing the decreasing temperature, uses this opportunity to release the eggs, thousands each time, into the water, thus contaminating it again or further. Thus the cycle restarts. Often these larvae are found in still or stagnant ponds. And here you have a picture showing what I just discussed, the life cycle of a Guinea worm disease. The water fleas ingest the larvae are ingested through drinking of contaminated water, then they burrow down through the cavity of the abdomen, and then the females then sit there and burst through the skin through the blister, thus contaminating water again. Who's at risk? Only 4 countries reported GWD in their waters: Chad, Ethiopia, Mali, and South Sudan. Anyone from these countries who has limited access to clean and purified water, especially any stagnant water sources, is in danger of becoming infected. Those who live in very poor villages are prone to it. Also, because not all countries record diseases and tell the WHO, anyone from a developing country or third world country is at risk of contaminated water. This parasite can infect people of all ages, so missionaries on a trip can contract the disease as well as local residents. Finally, those who have civil war in their borders are at the risk. from this disease. There are rules of prevention, one of which is to drink only water from protected sources that are free from contamination, aka boreholes or hand-dug wells. You could prevent people with swelling and wounds from entering ponds and other water used for drinking. This is because when they enter the water, the eggs are released. Filter drinking water from unsafe sources using cloth or pipe filters to remove the tiny fleas. Treat unsafe water sources with a larvicide, such as A-bait. It will kill the water fleas. Provide communities with new safe sources of drinking water, and repair broken safe water sources, hand pumps and such, if possible. And then educate the public on the danger of drinking unclean water. This will minimize the possible contamination of reservoirs. Pathology and immune reaction. Pre-emergent female worms move easily through the connective tissue, but when they are about to emerge to the surface, a few larvae are released into the subdermis. The host reaction results in the formation of a burning, painful blister, which bursts in a few days to give a shallow ulcer, and there is then a marked inflammatory response against the cuticle of the entire worm, preventing its removal. The bacteriologically sterile blister fluid contains larvae surrounded principally by polymorphonuclear neutrophils, with macrophages, lymphocytes, and eosinophils. After expulsion of thousands of larvae, the end of the worm dries up, and this process is repeated a few times, with the complete worm being extruded in a few weeks. Female worms sometimes burst in the tissue, resulting in a very large pus-filled abscess and severe cellulitis. Infertile females or male elicit a slight inflammatory reaction and sometimes calcify, showing up on a röntgenogram. Unfortunately, there is no immunity to this parasite, and anyone previously infected can contract GWD again. The response to the extrusion of larvae is indicative of an arthritis reaction followed by a delayed hyposensitivity. Some of the very common symptoms is that patients have slight fever, itchy rash, nausea, vomiting, diarrhea, dizziness. But many patients, in fact almost all patients, are asymptomatic for almost an entire year before they show symptoms. Then the blister develops on the skin, usually a lower half of the body, about 80% or 90% of the time. This blister starts to burn, then burst when placed into water, releasing thousands of eggs. Extracting the worm is painful, and without proper care, infection will follow. This can result in redness and swelling, boils, infections, joint infections, lockjaw. It can also cause disability for about 8.5 weeks, but sometimes it can be permanent, and death is very rare. The blister forms from a local itching, then sharp pain, and often general allergic symptoms, including urticaria, follow. Immunodiagnostic methods are useless because it has not been proved that they can detect pre-patent infections. However, they can use the elevated antibodies to detect the pre-patent infections, especially the detection of immunoglobulin G4. Basically, the tell is when a person develops a blister and the pain that accompanies it. Treatment. When winding worms on a stick a few centimeters a day, along with clean dressing and antibiotic ointment to prevent further bacterial infection. There is no proof that chemotherapeutic agents have a direct effect on the worms, but many benzimidazoles may have anti-inflammatory effects. Aspirin is also effective. Ivermectin has effects on many other nematodes, but seemingly none on this subspecies. The only sure way to treat this is to extract the worm and stave off any following infections, and then in the future clear the water supply. There's no vaccine that can make you immune to this bacteria. However, certain antibiotics can help prevent infection after the worm is removed. The most research that is being done is the eradication effort. It is a prime subject for eradication because there is no chance for the disease to return once the last human case occurs. It is easily diagnosed, not usually misdiagnosed. Very predictable when the cases will appear and the disease will be more prevalent, and it also has already been eradicated in many other areas. In the future, the eradication effort has decreased the number of cases exponentially. The Guinea worm's natural habitats are decreasing due to the elimination of contaminated water sources. It is unlikely that other outbreak will occur because of the reservoirs are decreasing. It is likely that in the next 5 to 10 years we will see a complete eradication of Guinea worm disease if the stats continue to drop as they have. If the war in Sudan ends, then we will see a decrease in cases. Other than clinics and doctors in the countries, not much is being done to give local residents cheaper therapeutics or treatments because of how limited the number of cases. The main thing that you can do is educate the residents and tell them about what are the dangers are when drinking contaminated water. These are my sources of information, and thank you.